Good afternoon, everyone. Welcome to our webcast, a 4-month regimen for non-severe tuberculosis in children, based on the SHINE trial, broadcast live from Heartland National TB Center in San Antonio, Texas, August 31st, 2023. While you're waiting, I would like to tell you about Heartland and the services we provide. Our mission at Heartland is to build capacity with our partners through expert medical consultation, cutting-edge trainings, and product development. Heartland National TB Center is the Frontline Texas TB consultation and education organization. We are located in San Antonio, Texas, and cover the 11 Texas Department of State Health Service regions, plus the binational program along the state's border. Dr. Seaworth, Dr. Armitage, and our other medical consultants are experts in TB, MDR-TB, pediatric TB, and TB comorbidities, including TB, HIV, and TB in patients with medical health issues. Consultation services can be acquired via phone or email. You can reach our warm line at 1-800-TEX-LUNG, or you can visit our website. Heartland conducts several trainings throughout the year. Our core courses include Introduction to TB Nurse Case Management Online, Essentials of TB Nurse Case Management Online, and TB Intensive. These trainings are held 2 to 3 times a year. Other courses are developed and implemented in collaboration with the host health department. Heartland also hosts webinars covering a variety of topics. The following are just a few of our upcoming courses for 2023. For more information and to register, please visit our website. In addition to conducting trainings, we also provide technical assistance by helping programs with course development and by providing resources for programs or partners to deliver trainings and planning calls. Along with all these great services, Heartland also offers clinical mini-fellowships for physicians and nurses. These are targeted to physicians, physician assistants, advanced practice nurses, RNs, and LVNs who would benefit from participation in an intensive learning experience in the management of patients with TB. Our goal is to share TB expertise and knowledge with healthcare personnel from a variety of settings. If you would like additional information, please contact Director of Education, Delfina Sanchez. Heartland also offers a variety of educational products, which you can download straight from our website, free of charge. Last but not least, we also produce a biannual newsletter, TBeat, which features case presentation highlights, regional highlights, resources, and journal publications. Archived issues of TBeat can be found on our website. If you have suggestions or questions regarding TBeat, we would love to hear from you. Please be sure to visit our newly designed website where you can view upcoming and archived trainings, apply for mini fellowships. You can find information about our consultation services, access our products, and find HNTC contact information. You can now follow us on Facebook. Stop by, give us a like, and share with others. We will have time for Q&A at the end of the webcast. Please use the Q&A pod to submit your questions. Now, for those of you who would like CEs, please listen to the following information. Disclosure to learners, a 4-month regimen for non-severe tuberculosis in children, based on the SHINE trial webcast, August 31st, 2023. Successful completion. Successful completion of this continuing education event requires that you complete registration and sign in, attend the entire event, participate in education activities, and complete the participant evaluation. Commercial support and disclosure of conflict of interest. This event received no commercial support. The speakers and planning committee for this event have disclosed no financial interests. Non-endorsement statement. Accredited status does not imply endorsement of any commercial products or services by the Department of State Health Services, Texas Medical Association, or American Nurse Credentialing Center. Off-label use. The speakers did not disclose the use of products for a purpose other than what it had been approved for by the Food and Drug Administration. Expiration for awarding contact hours and credits. To receive CEs for this webcast, please complete the evaluation by Friday, September 1st, 2023. An evaluation link and QR code will be provided to all participants in attendance at the end of the webcast. Participants that do not complete the evaluation by this date will not qualify for CEs. Continuing education. Continuing medical education. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Texas Medical Association, TMA, through the joint providership of the Texas Department of State Health Services Continuing Education Service and Heartland National TB Center. The Texas Department of State Health Services Continuing Education Service is accredited by TMA to provide continuing medical education for physicians. The Texas Department of State Health Services Continuing Education Service designates this live activity for a maximum of 2.00 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Nursing Continuing Professional Development. The Texas Department of State Health Services Continuing Education Service is accredited as a provider of nursing continuing professional development by the American Nurse Credentialing Center's Commission on Accreditation. The Texas Department of State Health Services Continuing Education Service has awarded 2.00 contact hours of nursing continuing professional development. Continuing education. Licensed nursing facility administrators. The Texas Department of State Health Services Continuing Education Service is approved to provide licensed nursing facility administrator continuing education hours per LTCR licensing and credentialing, HHSC regulatory services. This program has been approved for continuing education for 2.00 total participant hours. Please feel free to contact me with any questions you may have.
All right, welcome to our webcast. Before we begin, I want to go over just a few things. So please use the Q&A pod for questions. We will have plenty of time for questions at the end of the webcast. If you are viewing as a group, please be sure to have everyone in your group complete the sign-in sheet, which we've attached in the chat box. And then also everyone in the group must complete an evaluation if they would like to qualify for CEs. So for those who would like CEs, please be sure to complete the evaluation for this webcast no later than tomorrow, Friday, September 1st, 2023. CEs are only available to those who complete an evaluation by the deadline. And I will provide you with an evaluation link and QR code at the end of the webcast. Also, we will record this webcast and post it to the archive page on our website. This recording will be available on our website within the next week. And last but not least, please be sure to visit our website for our new products and upcoming trainings. So with that, we have some great speakers lined up for today. And I'll start off by introducing our speakers. Our first speaker for today is Dr. Lisa Armitage. Dr. Armitage is board certified in infectious disease, internal medicine, and pediatrics. She obtained her medical degree from the University of Texas Medical School at Houston to include her PhD in molecular pathology. Dr. Armitage has spent several years in the field of TB and is co-medical director of Heartland National TB Center in San Antonio, Texas. Our next speaker is Dr. Jeffrey Stark. Dr. Stark is an internationally recognized expert in the management of childhood tuberculosis and mycobacterial infections. He has participated in the writing of numerous clinical guidelines for the City of Houston, State of Texas, the CDC, the American Thoracic Society, the International Union Against Tuberculosis and Lung Disease, and the World Health Organization. Following Dr. Stark, we will have our panel discussion, which includes Dr. Andrea Cruz. Dr. Cruz is an associate professor of pediatrics at Baylor College of Medicine and the director of Children's Tuberculosis Clinic at Texas Children's Hospital, the largest pediatric TB clinic in the United States. Dr. Cruz also serves as a pediatric consultant for the Heartland National TB Center and has been a consultant for the World Health Organization. Following Dr. Cruz, Dr. Abby Geltmeyer. Dr. Geltmeyer is a pediatrician in Houston, Texas, and is affiliated with multiple hospitals in the area, including University of Texas Medical Branch and Memorial Hermann Hospital. She received her medical degree from the University of Texas Medical Branch School of Medicine and has been in practice for more than 20 years. So again, I'd like to welcome everyone, and we'll start with our first speaker, Dr. Lisa Armitage.
All right, Delphina, can you see my slides?
Yes.
All right. So I wanted to just say hello to everyone. Greetings from the hot state of Texas. A little toasty down here, but the way we're going to run the webinar today. I'm really excited to be presenting with the other speakers. We have a great group of very dedicated pediatricians down here in Texas. And so I'm going to start off by presenting a little bit about the SHINE trial itself. So this is the basis that we are wanting to look at seeing something for our children to shorten our regimen for children. And the beauty of this study, it is the one and probably first only study that is focused on children and tuberculosis, and not just kind of a pass off of something from the adult literature. And after I give a presentation about the trial itself, then I'm gonna pass it off to Jeff, who is going to give us an overview of just he's basically going to address the more practical uses of considering the regimen. So I'm going to turn my camera off so we can focus just on the slides, but start off with a little something about pediatric TB. So pediatric TB is different, like every other thing from adults. Tends to be paucibacillary, but generally more challenging to diagnose. And in the U.S., we're extremely fortunate that contact investigation activities have identified children much earlier in the course of disease. So we don't see a lot of the late disease that you see in other countries, for example. We tend to get children earlier in the diagnostic tree and diagnosing a child who has very few bacteria without essentially disassembling them and plating them out on a petri dish is a lot more complicated. But what we see in children is very similar to adult smear negative, culture negative disease. And we know that the shorter treatment course in adults tends to work. But what we don't know is if we shorten that, and didn't know, if we shorten that in children, that was still going to work. But the reason we don't have studies, children don't tend to transmit disease. So that makes them a lot less of a threat to TB elimination. So they just kind of tend to be forgotten. The treatment, TB treatment studies in children have lagged significantly behind adults at every point. And if you look at a lot of the newer regimens, they're willing to concede down to adolescents. They'll go down to 12 years of age, but a lot of the studies are excluding our children who are 12 and under. But again, most treatment recommendations are based on adult data, but adults have very different disease presentation and also tend to have a difference in metabolism. So the SHINE trial, this was basically shorter treatment for non-severe tuberculosis in children in Africa and India. I wanted to point out the lead author, Dr. Turkova. And I wanted to say thank you to her because she provided us some of her slides. So we had some additional information that was included mostly in the supplemental data, but she did provide some of the things for us to show. Now, real quick, and if all of y'all who know me know that I did tend to get on my soapbox and get a little fussy about how we get left behind in TB, but I want you to look at our history of treatment shortening. And we start off in the beginning. The first drug that was found to work against TB was streptomycin, and our first treatments were all streptomycin monotherapy, and a lot of people had resistance to streptomycin. So now worldwide, that's about 25% of isolates of TB that are isolated on this planet are streptomycin resistant, and this is why. Second drug that came along, really hard drug, PAS, very weak and very toxic. But we got to the 1950s and we got isoniazid. And so now we're getting the cores of some drugs. We also got PZA, cycloserine, and kanamycin, but most of the regimens in the 50s were streptomycin, isoniazid, and PAS. And this was a 24-month regimen of puking and getting shot in the backside. So not pleasant. We get to the 1960s, we have ethambutol, which is a much, behaves very similarly to streptomycin in what it does to TB. It's protective of the other drugs. It really doesn't do, it's not as strong, but it's not as toxic. So there was replacement of streptomycin with ethambutol, and now we have streptomycin, ethambutol, and isoniazid, and we're down to 18 months. So then we get to the 1970s, and we've had rifampicin. Finally, we have a drug that has been developed that actually has some teeth to it, like isoniazid, and we're seeing that added, and we're still with the streptomycin. I don't know, we still want to shoot backsides. I'm not sure what that was, but we're down to 9 to 12 months. But it was the 80s when we got the what we call right now, or HRZE if you're overseas. And now, so we have isoniazid, rifampin, PZA, and ethambutol, and we have the 6-month regimen. So it has taken 40 years to get to here, and then we have almost 40 years of silence. And I want you to notice in this gap here, just here, because the drug AZT had actually been discovered in the 50s, but it was discovered that in 1987, the FDA approved it for the treatment of HIV. So that was 1987. And so we have had 1, 2, 3, 4 new drugs, right, that have been developed since 1987, correct? And now we have one shortening regimen that we can only use in children down to 12. And this, just for reference, I'm going to do my little rant, are the drugs that have been developed for the treatment of HIV since AZT. If you look at the discontinuation medication group, that looks like pretty much our whole group of meds that we have available. So just my point. So let's move on to the study. So the design of the SHINE trial, it was a multi-center, and I'll show you where the centers were. It was open label. So already, the children could be referred to it, but it was a parallel group. So that was 4-month and 6-month regimen study. It was non-inferiority. So it was not actually meant to show, superiority, but a non-inferiority study. It was randomized and controlled, and it was a 2-arm trial. So it's actually a very well-run study. And it compared 4 months versus the standard 6-month regimen. It did use, so something very different from what we do. It used a fixed dose combination dispersible tablets. So they actually have a secondary analysis where they looked at whether the fixed dose medications were actually hitting the correct drug ranges for children. But of note, the fixed dose dispersible tablets have isoniazid, rifampin, and PZA only. You have to add ethambutol as a separate drug when you're treating. So the endpoints were favorable outcome and TB-free survival at 72 weeks. And the margin of inferiority, very similar to what you saw in the treatment shortening regimen with rifapentine and moxifloxacin, was set at 6%. When they chose the sites, They wanted to make sure that they didn't choose sites that were, that they wanted to have places where children may be different metabolically, may metabolize the drugs differently. They didn't want to do them all in one country. So they did 3 sites in Africa and 2 sites in India. And then the inclusion criteria. So as written, the inclusion criteria, the child could be age 0 to 16 years of age. Weight had to be greater than or equal to 3 kilograms. That was because they were using the dispersibles and they couldn't get the dosing correct down less than 3 kilograms. The clinician had to decide to treat, and with the standard first line regimen. So this is frequently what we do here in the U.S. We don't always have microbiologic confirmation that a child has disease. But if you have a child who has consistent presentation and is in the house with a person who has active pulmonary or disease and is infectious, or or is in a high risk setting, then yes, you would frequently make the decision without confirmation to treat. So this it's kind of set up like we see it, basically. So if you had, for example, said that every child had to be culture confirmed or not, then that's a different kind of study that you're doing. So they had to be symptomatic but non-severe TB. So what does that mean? They could have extrathoracic TB, so basically lymph nodes in the neck, axilla, groin. They could have intrathoracic, uncomplicated, hyaluradenopathy, which is what we see frequently. That is 2/3 of kids who have lymph nodes have them in their chest. Minimal or no parenchymal abnormality on chest x-ray, and smear negative on gastric aspirate or other respiratory samples. So if you had a child who was old enough to produce a sputum, then that sputum had to be smear negative. And if you did gastric aspirates, that had to be smear negative as well. So interestingly, the gene expert could be positive or negative. So if you had a gastric aspirate, it was smear negative, but the gene expert was positive, that child still qualified for the study. A negative gene expert could be used as a substitute for a negative smear if they only did expert and not smear. So culture of the respiratory sample could be positive or negative, but it had to be smear negative. So just like I said, those are the caveats. Smear negative on the respiratory sample, it could be gene expert positive, it could later on be culture positive, but the initial smear had to be negative. And lymph node aspirates, though, could be smear, culture, or gene expert positive. If it was a lymph node only, it could be positive by any of the testing means, or it could be completely negative. So they couldn't have been treated for TB in the last 2 years. They had to have known HIV status. So even though they enrolled both HIV infected and HIV uninfected children in the study, they had to be willing and likely to adhere to 72 weeks of follow-up, written consent, and then had to have a home where they're accessible for the study folks to come and visit with them. Exclusion, smear positive respiratory sample. So remember, that's a gastric or a sputum sample. If they were smear positive, that was not considered non-severe disease and they were eliminated. They cannot be premature and aged under 3 months. So if they were less than 37 weeks and they were also under 3 months of age, that was a no. Miliary TB, spinal TB, TB meningitis, osteoarticular TB, abdominal TB, congenital TB. I can think of several other TBs, but the important point is that these are not considered non-severe. So TB in any other major sites would need longer treatment regardless, and so that couldn't be considered for the shorter treatment. If they had pre-existing non-tuberculous disease, liver, kidney disease, anything that was going to prejudice whether they were having a side effect to the medication, that was considered an exclusion criteria. So any contraindication, obviously, to taking the anti-TB meds, known contact with a drug-resistant adult source case, and a known drug resistance in the child were all eliminations. And then a child who was just severely sick. So you had a child who maybe didn't have respiratory findings, just had the dwindles, as we call it. But if a child appeared severely sick, regardless of what your imaging or culture showed, that eliminated them, and also any children that were pregnant. So the methods were simple. They set out to recruit 1,200 children, and I'll tell you what they based the number on. But they were randomized to 1-to-1 to either 4 months of a 4-month regimen or a 6-month regimen. So the intensive phase in both arms was 8 weeks of 4 drugs. They added the E in parentheses because some countries they choose to add ethambutol and some countries they do not. So, and they did look at a subgroup analysis to see if there was a difference in that. So I'll show that later. But in the 4-month arm, the continuation phase is only 8 weeks, whereas in the continuation phase in the 6-month regimen is twice that at 16 weeks. So all children were followed up at 72 weeks. So after obviously the follow-up period was going to be longer in the 4-month group because they had a shorter continuation phase. But the 72-week evaluation was from the start of treatment. So this is the randomization pattern and the looking at the intent to treat. So the intent to treat was intention to treat group was basically everyone who underwent randomization. So these are some of the reasons that that of the children that were initially evaluated. So 1,461 patients were assumed to be eligible, and 257 were excluded. And so basically the overwhelming bulk of them, they did not have minimal disease. So that was the largest one. Some of them were smear positive, which was also something that they were eliminated on, too sick to participate. MDR, any exposure to someone with drug resistance. So all of those, based on the exclusion criteria, were excluded, and then they went to randomization. So we started off with the intent to treat group. This was a group that was randomized 602 to each arm. And then there were a few more exclusions that patients that didn't complete the therapy, and patients who died from any other cause. So they had some more eliminations, which made the modified intent to treat group. And then there were a few exclusions because they didn't adhere to the treatment. Now, I want to say something important here. These were not done by DOT. The medications were given by the parents at home. So how would you exclude someone for not adhering to the treatment, to the trial treatment? Well, if you found out that the patients were not being medicated according to what they were supposed to be medicating with, then they would be excluded. And just a reminder, so the intent to treat was everybody randomized. The modified intent to treat included all excluded late screening failures, those who didn't reach the 16 weeks of evaluation, those who completed treatment well and were lost before week 72 when they could be evaluated. And then those who were non-adherent, meaning they used what they call the 80-120% rule. So if they didn't get 80% of the daily doses within the 120% of the allocated treatment duration, they were eliminated. So that's kind of like with LTBI, if you're on a 6-month regimen, you have to complete it by 9 months, for example. This is very similar to that. So they did a very key secondary analysis. Every child that was considered to have TB at baseline was evaluated by an independent expert committee that were blinded to where they were randomized to, and actually evaluated whether they would have considered that child as having actual TB. So that was a second subset analysis. So remember, these were any physician that felt that a child had TB could, put them forward for enrollment in the study. So if the individuals who were actually, they had a subcommittee an expert committee that actually evaluated whether they felt the children actually had TB. How they got the sample size, they decided they needed a 6% non-inferiority margin. They were assuming 8% unfavorable events in the control arm. And so that was again how they were determining what number they need. They assumed that they would have 10% loss to follow up, and they wanted 90% power and 5% two-sided significance. So this is how they came up with the number of the 1,200 in the beginning. When you look at the characteristics of the children in the 4-month and 6-month arms, similar. There's not a whole lot of difference between them across the sites, across the weight bands, and then across their clinical presentation. I'm just noting that respiratory tuberculosis represented about 2/3 of the disease. There was a mixed respiratory and peripheral lymph node disease, and about another third, and then smaller percents had only peripheral lymphadenitis, and then there was the other. And with the culture results, all positive results was about 13 to 14%. Positive cultures were really low, which is kind of what we see when we do cultures in children here in the US. The expert positivity, being expert positive only, was low, because most of them, I think most of the places actually are doing more cultures, but that could be incorrect. It could just be that positive, expert positively only is usually tied to culture, and you see both, but both again only slightly higher. So I think the take home is that we just don't see a lot of positive results in our children, and that held up to what we normally see. The primary efficacy outcome was unfavorable status. So unfavorable status was considered either treatment failure, meaning that the treatment had to be extended because, like, for example, in the 4-month group, at the end of 4 months, it was felt that the child had not cured and they had to be extended. There were TB treatment drug changes, either for toxicity or other problems, and then restarts due to suspected treatment failure. So these were included in the treatment failure. Obviously, death is one. And then TB reoccurrence, death of any cause, and treatment lost to follow-up. So these were all considered unfavorable. And then there was another analysis looking at the primary safety and looking at children who had grade 3 to 5 adverse. These are considered severe adverse events on treatment. Interestingly, retention and adherence to randomized duration. We were chasing individuals all over the place, but when it comes down to kids, they had 95% that attended the week 72 visit and 94% that stayed on the allocated treatment. So overall, the children were treated according to the standard of care and treated and finished up for them to be evaluated. So it's always nice when you have most of the children evaluated to see how your study worked. And this is basically the outcome. So when you look at, remember the intention to treat was the entire group. The modified group was the ones who were eliminated that were actually not that didn't meet the criterion, and then the per protocol are the ones that made it to the end. But across all of them, at the line of 0 on the forest plot, you see with to the left showing 4 months of treatment being better and 6 months of treatment being better. They're essentially equivalent. And here's the 6%. I just had a brain fart, excuse me, but this is the allotable failure. Basically, the line of inferiority is set here at 6%, and you can see that none of the regimens gets close to that. This was a slide from Dr. Turkova that provided where they actually broke down whether, in looking in children less than or equal to, less than or greater than 3 years of age, very similar. Those, just for us, those who are taking ethambutol or not taking ethambutol, also very similar. There did seem to be a wide, a kind of, I would say that in children who were infected with HIV, had touched the line of non-inferiority, so it was not good. Looking at lymph node disease, again, not lymph node disease versus lymph node disease, no different. Male versus female, no real difference. And then other than this one site in India that actually touched the line of non-inferiority. But in these two groups, the numbers were very small. So I'm not sure what you can take from that. Looking at the safety outcomes, the primary safety outcomes, basically they were correct, and about 10%, about 8% of children were going to have side effects, and that was about what they saw in all of the groups, maybe in both sides of the groups. I think the take home is that it was very similar, in both groups. Serious adverse effects, again, the same in both groups. This was generally pneumonia or liver toxicity was what they found. And the deaths in the 31 deaths, they noted that 25 of those occurred in children under 2 years of age. And so these were the smaller, sicker, usually hospitalizations associated with those, but the smaller children had an increased risk of death, and it did not show difference between the two arms. The children with HIV, of the 31 deaths, 13 of them were children with HIV, and they just broke down the causes. Pneumonia in 6, epilepsy and convulsions in 2, and then 111 on one suspected pulmonary TB was the cause of death. But interestingly, deaths in the Shine trial overall, they looked at, it was about 2%. And looking at UNICEF and their under 5 mortality during the same period when they were conducting this trial, the deaths in the countries where they were performing it were all higher. So overall, our take home, basically, unfavorable status was about 3% in both arms. Deaths, again, were very low in each arm. Loss to follow-up was very low after the 4 months of treatment. TB recurrence, 6 in the 4-month group and 4 in the 6-month group, both at about 1%. The extension of treatment, there were only two children that were being under evaluation were actually had treatment extended. So that was one question about whether that was going to skew the results for the unfavorable status toward the 4-month, because the decision of extending treatment occurred at the treating physician. Only 2 children had to restart treatment, 1 in each arm. So favorable status, 97% in each arm. This was, I thought, interesting. I had not seen this, but she shared this slide. There were some children that made it through the study that actually had severe TB when they went back and looked at when the expert review panel pulled those kids in and reviewed that subgroup to determine if they felt the group had TB or not. And I had, let's see, excuse me, y'all, I don't want to make you puke running backwards, but one thing I did not note here is the key secondary outcome. This is the group of children that were evaluated by a separate expert committee who reviewed the imaging and all of the information provided on the children to determine whether they felt that the children actually had TB or not. And it was about 80% of the entire treatment group that they felt 20% of them were probably an overcall, but they are a different diagnosis. But there were 80% that they actually felt had TB. And in that group, it performed very well. So I just wanted to go backward because I forgot to note that on this slide. But let's run forward to here. So all children enrolled in the trial had non-severe TB that was as judged by the local clinicians. There were 71 children when they pulled in for central chest x-ray review that they actually felt had severe disease and should have been eliminated in the beginning. Of those, 16%, like 23%, were microbiologically confirmed by either gene expert or culture, but 94% of that group also had favorable outcomes. So the non-severe group was 97%. This group was 94%. And the unfavorable outcomes, they were suspecting that 1 child in each arm actually died, and had suspected TB, when they reevaluated them, and then at the 72-week point, and then there was 1 death in each arm. The death though from a solid tumor at week 28, and then from pneumonia at week 67. So these children had died before the 72-week evaluation, but these 2 children, there were 1 in each group that they felt had TB at the evaluation that had not been addressed. One other thing, this slide, again, another little tidbit of data. They actually did Mansu testing on several of the children. They didn't, out of the, all of them had TST testing, and then there was a smaller group that had quantiferon testing. So over overall, the overall group, about maybe, I'd say, this is about two-thirds of children had a skin test, and maybe about 20%, let's see, yes, only 3% had an IGRA. But if you look at the results, only 60% of the children that were enrolled in the study that had a TST were positive. So only about 60%. And it was even lower. You can't really say anything about the IGRA group because it was so few of them, but it was about half of them that were IGRA positive. So, not something we tend to do more screening where we are, but that was their results that they found. So this is Dr. Turkova's slide, what she felt like the caveats were. There was no standardized, case definition. The providers were encouraged to use NIH criteria for diagnosing a child with TB, but really it was based on the community physicians. About 50% of the subjects were contacts to known cases. So I don't know if they do that in other countries, but when we know that there's a child in the house and I have a bug out of the adult, my evaluation of the child is going to stop there. So I generally we don't do gastric aspirates, and we don't do, we might do sputums in an older child to see if that child is infectious, but in general, we feel like we have the diagnosis and we treat the child. The TST and IGRA results were not part of the case definition. So, all of these could affect what was being considered an actual case and not. So the three blinded reviewers in retrospect found that 80% of the cases were likely TB, and that non-TB in evenly distributed between the two regimens. So it wasn't that one side or the other had more cases. There was about 85% of the cases were likely TB, and the non-TB was equally distributed between both arms and should not have affected the outcomes. Positive AFB smears for the sputum was exclusionary, but not positive expert results. So in the handful of patients who had just an expert, maybe they would have been smear positive, but we wouldn't know. They use fixed dose pediatric combination dispersible pills that are not available in the US. Don't get me started on that. I can go on that all day, but I feel like we're getting robbed. They get some yummy mango and raspberry flavored yumminess, and we get a bunch of crushed pills that we're trying to hide in Nutella. But I would say I'm not bitter, but I'm bitter. But anyway, the ethambutol use was at the discretion of the local physician. And they really looking at the outcomes, as I showed you before, it didn't really show any difference whether or not ethambutol was used in this particular study. And there was no DOT. This was all self-supervised therapy with pill counts at the end of each visit. So at each visit, when they came in, they did pill counts to assess whether the patients were being treated with the meds and treated appropriately. But the take-home, basically 4 months of treatment was non-inferior to 6 months of treatment for children with non-severe disease. And the non-inferiority and adverse effects were very similar across all of the analyses that they performed. So it held up at every level that they analyzed this study. And the unfavorable outcomes are very few, about 3% in each arm. And side effects, treatment abandonment, and deaths are very low in children treated for TB. So we are doing a good thing when we move forward in our treatment of these children. And if you have any questions starting now, I'm going to ask you to drop those into the Q&A box. I am going to stop sharing my slides because I'm going to hand it over to Dr. Jeffrey Stark. I had the pleasure of introducing Jeff at a meeting once, and I think it was NAR, and I christened him the loudest voice for the littlest TB patients. So I'm going to hand him over to Jeff now. Jeff?
Lisa, thanks.
Hi.
I just want to make sure, can everybody hear me?
Yes, Dr. Stark, we can hear you. I'm sorry, Dr. Stark, I just want to interrupt quickly. Everyone, in this presentation, we will be using QR codes for polling questions. So please be sure that you can scan the QR codes when we get to that slide. Thanks.
Yeah,
get out
your phones, because we're going to show a bunch of x-rays and you are going to decide whether or not those children are or are not eligible for the 4-month regimen. So thank you all for being here. Boy, what a big crowd, and it's really nice to have you here. I'm honored to be able to give this to you to talk about some of the practical effects of this. What we're going to try to do here is talk about some of the practicalities. And let me just say in prefacing this that, in TB, we have studies that are done. And we, unfortunately, in this day and age, we're lucky if we get one study to prove a particular point. So the study has parameters. And one of the questions always is, can we as clinicians extend those parameters beyond what they did in the study, depending on the patient and the clinical conditions? In other words, are we bound by what they did in the study, or are there times when we can maybe go further or differently than what they did in the study? So I have no conflicts of interest, and I actually will discuss some off-label uses of diagnostic procedures, but it's kind of the thing we always do in childhood TB. And by the way, just so you know, when I click, it just, because of the way we're doing this, it takes a little while for the slides to advance. So by the end of this talk, we hope that you'll be able to better understand the rationale for multi-drug therapy of TB in children, and particularly as it relates to this subject. Determine the chest radiographic and clinical findings that make a child with pulmonary TB eligible for the 4-month regimen. Choose from different regimens the best treatment for pulmonary TB in an adolescent. And then use of interferon gamma. I'm going to tell you just about a couple of new wrinkles at the end that are going to be in the 2024 American Academy of Pediatrics Red Book, a little bit beyond the SHINE trial, but things that are going to be really important, I think, to everybody who's listening to this. So I want to review the whole concept of drug resistance in TB because it's very relevant to what we're talking about. So I always say the development of drug resistance is the result of a conspiracy among the organism, the patient, the doctor, and the healthcare system. Given the nature of the organism, if the patient messes up and doesn't take the medicines properly, the doctor messes up, doesn't prescribe them properly, or the healthcare system doesn't provide them appropriately, it will inevitably lead to the development of drug resistance, at least in adult patients with cavitary TB. And that's a very important thing because the burden of organisms in children is generally much lower than it is in adults. And you'll see in a second why that's so important. So drug resistance, the genetic loci for resistance are on the chromosome. There's no plasmids like there are in, say, gram-negative organisms. So it's all on the chromosome. And fortunately, the loci on the chromosome for different drugs and drug resistance, they're not linked. So resistance to one drug or class of drugs is independent of resistance to other classes or other particular drugs. Now, we know the frequency of mutations in many of those loci. That's important because a lot of what I'm going to present to you is really a mathematical argument in terms of what is drug resistance and how does drug resistance actually occur. And because we know rates of mutation, it means the larger the mycobacterial population, the more likely that drug resistance will occur. So here's how we look at this graphically. Let's take an adult with cavitary TB. And there's a pretty good estimate they have about 10 to the 9th organisms. Well, we know the frequency of mutations for isoniazid resistance is about every 10 to the 6th replication, and for rifampin about every 10 to the 7th. So that means by definition, an adult with cavitary TB has 1,000 organisms that are resistant to INH and 100 organisms that are resistant to rifampin. Now, the laboratory will still call this drug susceptible TB because it can't detect resistance down to that very, very low level. But those resistant organisms are there. So let's say we treat this patient with INH alone. Okay, we're going to kill all the rifampin-resistant organisms because remember, the likelihood of having even one organism that starts out resistant to both drugs is the multiplicative, so it's 10 to the minus 13th. So in a population with 10 to the 9th organisms, the chance of even having one germ that starts out resistant to INH and rifampin is just about 0. So the INH will kill all the rifampin-resistant organisms, and most of the isoniazid-resistant organisms, most of the other resistant organisms will get killed, and the patient will temporarily get better. But the INH-resistant organisms, nothing will be keeping it in check, and so they will start to replicate, and this person will now relapse with completely INH-resistant tuberculosis. But again, 10 to the 2nd of those 10 to the 9th INH-resistant organisms will also now be rifampin-resistant. And if we just then add rifampin to that, we'll have exactly the same problem. And that's how you create multi-drug resistant tuberculosis. That's how it happens. But let's say instead we had treated the patient with INH and rifampin. Well, the INH will kill the rifampin-resistant organisms. The rifampin will kill the INH-resistant organisms. All the organisms are killed and the person is cured. And that's the basis of multi-drug therapy for tuberculosis disease. I'm an infectious disease doctor. There's no other infectious disease that's sort of like this, where we have to do these multiple medications, and it has to do with a mechanism of resistance that occurs. Now, how can we treat people with TB infection with a single drug, INH or rifampin, and it works? Well, very simply, if you have a much smaller burden of organisms, 10 to the 4th to 10 to the 5th organisms, the chance of having even one INH or one rifampin-resistant organism is not 0, but it's very, very low. And then on top of that, the majority of people who are infected will never develop TB anyway. That's almost another log. So it has enough effectiveness in that situation that we can use that programmatically to treat people with TB infection. So it's all about the body burden of organisms. And the adage we often say is more bugs, more drugs. So a really important thing is, where does childhood TB fit into all this? So for most little kids with TB, especially with non-severe disease, the burden of organisms is probably way lower than it is in adults. This has never actually been measured. So is it really closer to TB disease in adults, or is it really closer to TB infection? That's a really interesting question. And so a lot of our conventions are, if we see an abnormal chest x-ray, we treat them as if disease. But I'll tell you a little secret. Back in the 1950s, when 125,000 people were treated for the first time with isoniazid to try to prevent them from developing overt TB disease, there were many children in the trial. Many of those children had abnormal chest x-rays, and they had chest x-rays that we would now call non-severe TB, often in large lymph nodes, for instance. And they treated them with INH alone. You know what? They did well. They did fine. I am not telling you that we should be treating those kids as if they have TB infection. I'm not telling you that, but I'm bringing that up as an example of what I'm talking about and how we have to understand these things when we're understanding trials and drug regimens in children as opposed to adults. This, as you can imagine, is very important when you're treating multi-drug resistant TB. And we now have to figure out sort of how many drugs a child needs to get and for how long compared to what's done in adults with their much bigger burden of disease. The other question, of course, is, when does TB infection turn into TB disease? Well, if you define that microbiologically, it's when you cross the threshold of the number of organisms is such that there's more likelihood of developing resistance if you treat with a single drug. What are the clinical correlates of that? I have no idea. Nobody knows. So our convention is, if you can see it with your eyes, an abnormal chest x-ray, or you feel it with your fingers, an abnormal exam or extrapulmonary TB, we consider that to be TB disease and we treat accordingly. That's a convention, but that's the best that we have. Much of what we see on the chest x-ray in children with TB is not really the burden of organisms, but it's the child's immunologic response. A lot of it is enlargement, inflammation within the lymph nodes, which then causes blockage of the bronchial tree, which can cause either hyperinflation or ultimately atelectasis. So if you have two relatively asymptomatic children, both recently infected, one is a normal x-ray, one has hilar adenopathy and maybe even a little bit of collapse of the middle lobe, is the body burden of organisms really different in those two children? We don't know. I don't know. Our convention is that the former would be treated for TB infection, the latter would be treated for TB disease. And of course, one of the reasons for that is children tolerate TB medicine so well that we don't want to take a chance on undertreating TB. I'm only bringing all this up because it's really important when you're considering trials. And this, as Lisa said, is the only trial we're going to get like this, about how do we actually use this information and how can we go beyond what the study did maybe to figure out how to use it in other situations other than those strictly in the trial. So these are the four basic medicines: INH, rifampin, ethambutol, PZA. The way I think about these, INH and rifampin are the workhorse drugs. They are the major killers. Ethambutol prevents the emergence of resistance among those small number of organisms that are either INH or rifampin resistance, keeps them from replicating. And PZA is like a magic medicine. We don't even know exactly how it works, except that if you add it to these other drugs, it shortens the amount of time that you have to treat tuberculosis. But if you put it in a test tube with a bunch of TB germs, doesn't do a thing. Even if you add some white cells, doesn't really do a thing. But it clearly somehow facilitates the killing being done by INH and rifampin. So what do TB drugs do? They do one thing. That's it. They kill TB germs. They don't reduce inflammation. They don't shrink lymph nodes. They don't absorb pleural fluid. They don't close cavities. They don't do any of those things. The host has to do those things. So remember that many children successfully treated for pulmonary TB with a 6-month regimen still have radiographic abnormalities at the end of therapy. We know that. So what about the 4-month regimen? Well, we certainly would expect that they're going to have radiographic abnormalities as well at the end of 4 months of therapy. So what does that mean? Probably doesn't mean much of anything. Does it mean we should get an X-ray at the end of 4 months? Or should we not get an X-ray at the end of 4 months because if the child's otherwise doing well? That's frankly kind of an open question, but we would expect that some of them will still have an abnormal X-ray at the end of 4 months therapy, just as they do at the end of 6 months therapy. One thing the study really doesn't address is what kind of analysis or whatever we should do of kids at the end of 4-month therapy to decide whether or not therapy needs to be extended or not. That information is unknown to us. So again, the SHINE trial, I'm not going to go through this. This is what Lisa just went through, but I do want to just draw your attention to what's at the bottom of the slide on the red. The decision to choose a regimen was made at diagnosis, not at the 4-month mark. So patients in the 6-month control group got the full course regardless of their clinical or radiographic evaluation that may have been done at 3 months or 4 months or whatever. In other words, there's nothing in this trial that says, okay, start them on the regimen and then evaluate them at 4 months. And if they have this criteria, you can stop the medicine, or if they have this criteria, you have to go for 6 months. That was not part of this trial, and that may be something that we need to figure out over time as we start to use the 4-month regimen more than we're using it now. So you heard about this. I won't spend much time. The inclusion criteria here as well. Let me mention the whole thing about sputum smear and an expert and culture. Of those 3, in children, sputum smear is the least sensitive. So what that means is if your smear is positive, it predicts you have a larger burden of organisms, and that's the reason why they didn't want kids in the trial with a positive sputum smear, but they did allow a positive expert and or a positive culture ultimately. And then the definition of non-severe, I'm just going to go over it because we're about to look at some chest x-rays, and this is what you're going to be looking at. It should be confined to what they said was less than 1 lobe. So in other words, an expansile pneumonia involving 1 lobe was considered to be severe TB, regardless of the child's symptoms or anything else. Can't have a cavity. You can't have significant airway obstruction, although there was no definition of significant airway obstruction. No complicated pleural effusion. You could have a little pleural effusion and certainly pleural reaction, but not as a complicated pleural effusion, and no miliary or evidence of disseminated TB. And you could have peripheral lymph node TB as a criteria. So keep these things in mind as we look at chest x-rays. I'm going to skip this because you already heard about this from Lisa. And then the caveats, again, Lisa showed you this slide as well, just to remind you of some of these things, and we'll come back to this sort of at the end, how these should or shouldn't affect what we end up doing with our patients. Okay, so here's a question. If the patient did not fit the SHINE criteria for 4-month therapy at diagnosis, but symptoms and radiographic findings have resolved at 4 months of therapy, can we stop the treatment? Well, we can't stop the treatment based on the SHINE trial because the SHINE trial didn't address this particular question. We as clinicians, however, are certainly allowed to address this particular question, and it's something maybe we can talk about during the Q&A. So here we go. So get your phones out because now we're going to start the part with audience response. And I'm going to show you now a series of chest x-rays, and then I have some clinical vignettes. And we need to decide whether these kids are or are not eligible for 4-month therapy. So this is the first one. We have a PA and a lateral chest x-ray. Take a look at it for a second. And then I'm going to go to this particular slide, and you see the barcode up there. So open that up with your phone, press on the little yellow button. and put in whether you think yes or no eligible for 4-month therapy. And I don't want to spend too much time, but I'll let it go for a while. Okay, so we're kind of settling in pretty close to 80-20. I'll be honest with you, this is a trick question because that's a normal chest x-ray. And I put that up there intentionally because telling the difference, if you haven't had much experience with childhood TB, between what's normal and what's abnormal can be very, very difficult. And especially when you're looking at the hilar region and considering whether or not there's actually something there other than pulmonary vasculature. Technique is critical with childhood chest x-rays. We have 3 parts of technique. We have whether or not they took an adequate breath. And Andrea Cruz and I have x-rays of kids taken even 15 minutes apart with a bad inspiration, and it looks like they've got a mediastinal or hilar mass, and then a good inspiration, it actually looks completely normal. The other thing you have to remember is the mediastinum is not cylindrical, it's actually elliptical. So if the child is rotated even a few degrees, it can make the mediastinum or hilar region look more prominent than it actually should. So what's going to be critical in these decisions is paying really good attention to technique of the childhood chest x-rays. And if you don't get a good x-ray, you should send the child back for another one if you can't make the decisions based on whatever radiograph you actually have. So that's the only trick question I'm going to give you, because that actually was considered to be a normal chest x-ray. So take a look at this particular chest x-ray. And then, so, I mean, what you see here is a lesion here and a lesion here. So whether or not you think this is eligible for 4-month therapy. Okay, we're getting about 75-25. Again, this is a tricky one because this is actually more of a Ghosn complex with calcified parenchymal lesion and a calcified lymph node. Some people would categorize this as disease because of the size of the calcified lymph node. Other people as infection. I don't think there is one right answer. And again, remember, a lot of what we're talking about here is sort of the burden of organisms when we see something on a chest x-ray. So if you're going to treat this as disease, I think clearly this is eligible for the 4-month therapy. And that's really the point of my showing it to you. Next slide, please. Okay, here's an x-ray. And you can see here, there's clearly something. Can you see my pointer, Delphina?
No.
Probably not now. Okay. Something over on the right-hand side, the child's right. So let's go to the question. So do you think this child, and by the way, I'm not giving any clinical information, but there, for all these cases, there's clinical reasons, either exposure or positive tests or something. These children were all children that were being evaluated for tuberculosis. Okay, well, this is about 2/3 no, 1/3 yes. To be honest, this child clearly is eligible for the 4-month therapy. This is a child who has hilar adenopathy. Those are lymph nodes. Those are hilar lymph nodes. This is a child whose mother happened to have pulmonary tuberculosis. This kid is completely asymptomatic and had a positive test of infection. And has this x-ray, which is hilar adenopathy, which is considered disease. And this child absolutely would be eligible for 4-month therapy. Next, please. Okay, here's another x-ray. Take a quick look at it before we go to the next. Again, all these have to do with TB exposure or reasons why the child might have TB. So let's go to this choice slide. So let us know, do you think that this child would be eligible for 4-month therapy? Okay, well, this is trending a little bit more toward 50-50. I would say the answer is yes on this also, because what's going on here anatomically is this child has enlarged lymph nodes and has some infiltrate and probably atelectasis extending into the right middle lobe. But remember, the criteria is having infiltrate less than 1 lobe. In other words, it doesn't involve a whole lobe of the lung. And remember that disease in children tends to come from enlarged lymph nodes. So it's almost a given that they're going to have enlarged lymph nodes when you see other manifestations on the chest x-ray. So this child would be considered to have non-severe disease and would be eligible for 4-month therapy. See how difficult this is, you guys. That's why we're doing this, is to really kind of go through criteria and what it means. Next one, please. Okay, here's a obviously abnormal chest X-ray. And let's go to the choice slide. Do you think this child would be eligible for 4-month therapy? Okay, we're settling in around 70-30, and I agree, the answer is no by the criteria of the SHINE trial. This child has massive adenopathy, you can actually see it. And then the line going across is actually the horizontal fissure that's being pulled down because of obstruction from that lymph node. So remember, one of the criteria for not being called non-severe TB is having significant obstruction. And this clearly is at a minimum significant obstruction, and it actually involves an entire lobe in this case. So this would be adjudicated as severe tuberculosis, and this child would be treated under the 6-month regimen. Next slide, please. Okay, here's another child with obviously abnormal chest X-ray. So what do you think, 4-month therapy or not? Okay, we have almost a consensus here about not, and I certainly agree, because this is the very definition of an expansile pneumonia. That is actually the entire upper lobe. And when you see X-rays like this in kids with TB, it's not unusual that they come in having fever and cough and they're symptomatic. And often they get treated for community-acquired pneumonia, and they sometimes get better. And the reason they get better is they have these obstructive lymph nodes, and they get a secondary pneumonia behind the obstruction. And it's actually the secondary bacterial pneumonia that brings them to clinical attention and helps contribute to the expansile pneumonia. So when you treat them with antibiotics, they get better, but they still have pulmonary tuberculosis. So that's just a caveat that's a little different, but clearly this kid would not be eligible for 4-month therapy. Next one, please. Okay. So what's going on the left side of this particular kid's chest? This was a child who came to us from California. Not that that has anything to do with anything, but so what do you think? 4-month therapy? Okay, again, 90% no. So what you're seeing on this X-ray is actually bronchiectasis. This is a kid with long-standing tuberculosis and has cylindrical bronchiectasis of almost that entire left lower lobe. She'd had some partial treatment. Eventually, she ended up having surgery because that was pretty much non-functional lung, and she kept getting repeated bacterial infections in there. So yeah, no, that kid with that kind of a X-ray would never be eligible for the 4-month therapy. Next one, please. Okay. Something going on over there on the left side. So what do you think about this particular one? Yeah, this one's a little bit trickier. I think that probably the answer would have been no by the study criteria of the SHINE trial, that this was pretty extensive involvement of that one lobe of the left-hand side. And I think people, and there's actually a little bit of involvement maybe of the lingula as well. So I think people would be, they would not have accepted this case in the SHINE trial. Remember, again, study criteria, they would not have accepted this particular case as being eligible for entrance into the trial in the 4-month therapy. Next one, please. Just a couple more of these. Okay, this one should be pretty easy and pretty obvious to everybody. Oh, I guess I was wrong about that. So what are you seeing over there on the right-hand side? Those are cavities. This is cavitary TB, that were the round circle that you can see. And cavitary TB is absolutely exclusional from the 4-month therapy. So but this person absolutely would not be eligible for the 4-month therapy, either in the trial or in real life for that matter. So cavities, no, not eligible for short therapy. Next one, please. And this one is pretty obvious too. Yeah, this should be 100% no. This is miliary TB, a disseminated tuberculosis of the lungs. And of course, this would never be eligible for a shortened TB regimen. So let's do a couple clinical scenarios. Okay, so this is a 3-year-old child who's a household contact of a case with AFB sputum smear positive. The child doesn't have AFB sputum smear positive, the source person does, and expert negative pulmonary TB. The child is asymptomatic, and the chest x-ray shows this right middle lobe infiltrate with possible hilar nodes. So would you think that this child would be eligible for 4-month therapy, yes or no? Okay, about 80-20. I think the answer is clearly yes in this case. And again, we've seen a variation of this already. You can have hilar nodes, and there's most of that process is probably some atelectasis, but I would not call it severe. It's not expansile. It's not severe. So yes, this child to me absolutely would be eligible for 4-month therapy. Again, probably a low body burden of organisms as well. Next one. Okay, previously healthy, fully vaccinated 4-year-old child from India has had cough for 4 weeks and lost a few pounds. You're going to notice, by the way, the chest x-ray is identical. So the clinical scenario is changing. Let's go over it again. Previously healthy, fully vaccinated, 4-year-old child from India who's had cough for 4 weeks and he's lost a few pounds. Clinically diagnosed with pneumonia, no improvement with a course of amoxicillin, had a BCG vaccine as an infant. His skin test is negative, but his quantiferon is definitely positive. Is this child eligible? Does the history make any difference in this case? Okay. So about 60-40. So this is a tough one because remember, one of the things on here is you have pretty good feeling that this is drug susceptible TB. Well, remember when we start a 6-month regimen, we also think we have a pretty good feeling that the person has drug susceptible TB as well. And so remember, the majority of people in India have drug susceptible TB. Yes, there's a lot of drug resistant TB there, but the majority of people still have drug susceptible TB. So there's really nothing about his story or history or x-ray that precludes him from qualifying from the 4-month therapy. Yes, he has a positive quantiferon. That's okay. That doesn't change anything. We certainly see kids with negative skin tests and positive quantiferons for various reasons. The source case doesn't really come into play here very much unless we know that they have drug-resistant TB. And remember, even mono-resistant TB, so INH resistance, knocks the kid out of being eligible for the 4-month therapy. So probably this child still would be eligible for 4-month therapy. But I know if I were doing this, I certainly would be very careful and follow this child. And I'd probably get an x-ray at the end of 4 months just to make sure that we're making progress in it. Last one. 2-year-old whose father has left upper lobe cavity, AFB positive sputum smear, expert positive, negative for rifampin resistance. That's the dad. Child's had a cough for a couple weeks, fever by palpation, lost a little bit of weight, has a positive QFT, but has a 2.5 centimeter fixed mass, likely lymph node, in the right cervical chain near the supraclavicular area, and has this x-ray. The x-ray is small, so I'll just tell you that the chest x-ray is normal. So has a normal chest x-ray, but has this mass. In other words, very probably has peripheral lymph node TB. So is this child eligible? So the answer is yes, as 80% of you said, this is peripheral lymph node TB. Now, the number of kids with isolated peripheral lymph node TB in the study was pretty small. But if you add the ones that had both pulmonary disease and lymph node disease, it was pretty good size, about 30% of all the patients overall. I'm always a little leery, frankly, about lymph node TB because I've always found that it's a little bit harder to treat. But the data are the data. And so according to the SHINE trial, this child would be eligible for 4 months of therapy. But again, I would certainly follow this kid clinically very carefully. The other problem with peripheral lymph node TB is just as the lymph nodes in the chest can take a long time to resolve, well, peripheral lymph nodes can too. And remember, what do TB medicines do? They kill germs. That's it. They don't shrink your lymph nodes. So one of the hardest things I find in cervical lymph node TB is kind of what's my endpoint? How much improvement do I need to see before I can say that I can safely stop the medications? That's an issue now, and I think it'll also be an issue as we do the 4-month therapy. Okay, next slide. So what are some of the unresolved issues for using this 4-month regimen? Well, What assessment, if any, should be done at the 4-month mark? Should we be doing a chest x-ray to make sure we have adequate improvement? If the chest x-ray happens to be normal, can we stop the therapy? How comfortable, how much radiographic improvement is required to feel comfortable if we decide to do that? How do we deal with breaks in therapy due to either drug intolerance or diminished adherence? We don't have any rules for that. And there really was nothing in the SHINE trial report that gave us any insight into that. So, if the child misses 2 weeks or something, what does that mean? We really don't know. I would say we would follow the same rules that we follow right now. Health departments tend to count numbers of doses. Remember also that this was not intermittent therapy. The trend in treating childhood TB is to no longer do intermittent therapy, to be honest. WHO really doesn't like intermittent therapy. They really want therapy to be daily for the most part, whether it's DOT or not. Again, we don't really know exactly how to deal with this. But I would say counting doses is, but we don't have a rule like we do with, say, 3-HP. You have to have a certain number of doses over a certain amount of time, the 80-120 rule that Lisa told you about. And so maybe the 80-120 rule is a pretty good approximation for us if the kid gets at least 80% of the doses. Personally, though, I don't think 80% is enough. And if we're using DOT, then 80% shouldn't be what we're looking for. We really should be looking for pretty close to 100%. The trial allowed for a positive expert, but not a positive smear. What about a positive culture? Well, it did allow for positive cultures, and that's okay. That doesn't change anything. And then what is significant airway obstruction? And I showed you some x-rays where it was obviously very significant, some x-rays where it was less significant. And frankly, does it really matter? Because is the airway obstruction really due to the immunologic response of the child, or is it really due to the body burden of organisms, which is what we're talking about with the drugs? So we don't have steadfast rules for that, and all of us, including us, are going to have to sort of feel our way through that. Next slide, please. I'm going to go away from SHINE for just a minute to tell you about a couple other things quickly that are going to be in the 2024 Red Book. In fact, are already on the Red Book online. And that is the new regimen for treating tuberculosis in adults. That is 4 months of daily isoniazid, rifapentine, pyrazinamide, and moxifloxacin. And they found that this particular regimen was non-inferior to the 6-month regimen of INH, rifampin, PZA, and ethambutol, the classical RIPE therapy. What's important about this is that they did include some adolescents in this study. Next slide, please. So the SHINE trial was kids 16 years of age and younger, and this was for kids that were 12 years of age and older. So we have that group of kids between 12 and 16 years of age who, if they have non-severe disease, could be eligible for the SHINE regimen, could also be eligible for this regimen. But if they have severe disease by the SHINE trial, then this regimen would be considered adequate for them as well. So for adolescents, we have even a little bit more choice than we do with the younger kids, and it still would be based on the severity of their particular disease. WHO and CDC already have endorsed use of this regimen for persons 12 years and above with drug-susceptible pulmonary TB, as now has the American Academy of Pediatrics. So this is a very viable regimen now for kids. Even kids who have pretty severe disease can be treated with this particular regimen. The adolescents in this study, and there weren't that many, there were only about 70, but they tended to tolerate these drugs really, really well. They did well, had very few adverse outcomes, and none of them relapsed. So this looks very promising as an alternative regimen for adolescents. Next slide, please. And then I just want to tell you about the trend in treating multi-drug resistant TB, all drug resistant TB, is all oral regimens. And now with the availability of bedaquiline outside the United States, the Laminid, although we can get it through an IND, repurposed drugs like linezolid and clofazimine, we now can treat the vast, vast, vast majority of kids with multi-drug resistant TB with all oral regimens. We don't have to give them injectables, although it's not that easy. And let me tell you why. Next one, please. So Dr. Cruz and I currently have a patient in the hospital, a little child, 6-month-old, with multi-drug resistant TB, US-born female, no previous medical history, had 1 week of fever, cough, congestion in the setting of a very abnormal x-ray. I'll show you in a second. The source case is actually her step-grandfather, who is now hospitalized at the TB hospital in San Antonio. Her skin test was 0, but let me show you her chest X-ray. Let me show you the next slide, please. That's her X-ray. Her quantiferon was positive, by the way. Her skin test was negative, quantiferon was positive. She's a normal host. We've done a little immune workup, no HIV, nothing. This was her X-ray, pretty remarkably abnormal. Next slide. So she originally was started on levofloxacin, linezolid, ethambutol, PZA, and amikacin, and rifampin. This is before we had the full result. We just knew that the grandfather had positive MTB and rifampin resistance by expert. But we now know that his isolate is resistant to INH, rifampin, PZA, and streptomycin, but does not have mutations and is not phenotypically resistant to fluoroquinolones, linezolid, amikacin, bedaquiline, clofazimine, and ethambutol. So the classical regimen, next slide, please. The classical recommended regimen now for this kid would be to be on linezolid, bedaquiline, and levofloxacin as the first order drugs. Clofazimine and cycloserine as the second order drugs, and then possibly additional drugs if thought to be necessary. But those 5 drugs would be considered the main regimen. We changed her to linezolid, levofloxacin, ethambutol, cycloserine, and amikacin because we could not immediately get clofazimine and bedaquiline. In fact, we're now over 6 weeks into this, and we still don't have bedaquiline and clofazimine. We don't have clofazimine because we're still waiting for all the approvals from the FDA and the company. And we don't yet have bedaquiline because there's a problem with this kid's Medicaid. For some reason, the company won't release the drug to us because they don't recognize the Medicaid number that this family has, even though we have checked and make sure that it is in fact the correct Medicaid number. So my point being, it's lovely to say we're going to do these things, but sometimes there's practical considerations. So we have kept her on amikacin. Her hearing is fine. Her creatinine's fine. She's just getting it once a day. We also measured drug levels through Chuck Peliquin at the University of Florida, and they were all therapeutic except for the cycloserine, which was actually high. So we had to lower the dose. We're also giving her B6 because of cycloserine. So we lowered the dose, and she now has cycloserine levels in the therapeutic range. But think about a little 6-month-old and all these medications that are, for the most part, we do have linezolid suspension. We do have levofloxacin suspension. But all the rest of these drugs are for the most part, made for adult patients. The multi-drug formulations Lisa alluded to in her talk are simply not available in the United States because one of the companies involved in the manufacture does not have an FDA license. So we're still stuck giving the same drugs we give to adults. She was vomiting the levofloxacin, so we actually changed it to crush pills, and now she's doing well. Fortunately, no lab abnormalities, tolerating everything, and we're just waiting to get either bedaquiline or clofazimine, and then we'll stop her amikacin and send her home to be followed as an outpatient. But anyway, so all oral regimens are great, but there are practical considerations that make it much more difficult in the United States, actually, than most other parts of the world. Next slide, please. And then this is her X-ray, fortunately, at 4 weeks of follow-up. So even with what really is kind of a weak regimen, she's clearly getting somewhat better, although she has a ways to go. And she looks great. She's incredibly cute. And she's asymptomatic. So next slide, please. So last thing I'm going to mention is that the AAP is now going to endorse the use of IGRAs in children of all ages. So we are lifting the age restriction on the use of IGRAs. So you can use an IGRA on a 6-month-old if you want to. There was a literature review. I was involved in this. Experience with IGRAs under 2 years of age included 6 different studies, 4 cohorts of high-risk kids, for which results expressly stratified kids for 0 to 2 years of age. The patients were followed for at least 3 to 5 years after the testing, and most children were case contacts or were born in tuberculosis endemic regions. None of the 575 kids that they looked at who had negative IGRA progressed to disease, including 70 who were skin test positive, IGRA negative. None didn't get treated. None of them have developed disease. And we know from epidemiology that if they were really infected, we would have expected some of these kids to go on and develop disease. So based on this study, basically, the AAP in the 2024 Red Book is going to say no more age restriction. Anytime when you would have used a TB skin test, you can use an IGRA in its place, which I know a lot of people are very happy about. Next slide. although that may, so that's what the Red Book's going to say. Can use IGRAs in children of any age and for all the same indications as the tuberculin skin test. Next slide, please. And I think that's it. So thank you very much for your attention. Again, the SHINE trial, the 4-month regimen, is a wonderful, wonderful thing. And now you and I get to decide all the practical issues about how we're actually going to use it. So thank you very much for your time and attention.
Thank you, Dr. Stark. So now we're going to go ahead and go to our Q&A panel. So I would like to ask all of our speakers to please turn on their webcams. And now we will be addressing questions from the audience. So the Q&A pod is located at the top menu bar. It's next to the chat button. If you click on that Q&A icon, then it should open up the Q&A pod where you can ask questions.
So I'm going to start off. We have one question that was in the chat earlier. Why was severe TB excluded in children? Was there a thought of including and assessing at 4 months? Just to answer that quickly, like Jeff said, more disease, more drugs. It's going to take longer time to kill off all of the organisms. So I don't think that was ever on the table. I don't think any of us, as TB clinicians are comfortable giving them, giving short shrift to our little ones that need a little bit more time to kill off the bugs. But there's a question in the box by anonymous user, and I really wish anonymous user was not anonymous because it's awesome questions. So he says, Dr. Armitage, SHINE, as in the real world, had low microbiologic TB proof. It was about 14% of microbiologically proven children in TB. Among them, the success with the 4-month side was 85% of 85 patients had culture proven TB. And the 4-month side, they had 89% success. And on the 6-month side, there were 80 patients, equivalent, and they were 92% success. So the two questions: would you suggest clinicians favor 6 months over 4 months for children with microbiologic proof, maybe more, or suggesting maybe more organisms of MTB? And since I like to talk a lot, I'm going to go ahead and hand it over to my other panel and let them discuss. If you were advising someone and you knew that there was a positive culture, what your thoughts were on that. Then I'm going to give you some caveats, of course.
I think based on the results of this study, having smear negative, culture positive, should not necessarily prompt you to move from the 4-month over to the 6-month course of therapy. And I think in part it's because I think the epidemiology of TB in the countries that were looked at is really, really different than what we see in the States. And Jeff alluded to this in his talk, right? So, when we think back to our clinic and Abby's clinic as well, it's, many of the children we diagnosed with disease are asymptomatic kids who are picked up during contact tracing. So they're in a very different part of their natural history than a child who comes in who is presented to medical attention through passive surveillance, e.g. they already have symptoms. So I think particularly in the US, that wouldn't be the rate limiting step. I do think if a kid has a cavity and is in that chest x-ray that Jeff said, I would automatically toss them off the shorter course of treatment because, my gosh, for the kids with the cavities, we're still treating the way you would treat an adult with cavitary disease. So I wouldn't feel comfortable even necessarily with them being on a 6-month course of therapy necessarily.
The other problem, if I may say, is this happens all the time in TB, and in fact in medicine, is we're treating severe and non-severe like they're discrete variables, when in fact there's a continuum. And so, just as when we looked at x-rays just now about trying to determine what was the right x-ray criteria to go for one for the other, I'm sure in the study that was similarly true. And so I'm not surprised that there probably were, I'd love to know the x-rays on the kids who were microbiologically proven. We also don't know the bias of selection of who they actually attempted cultures on, because they didn't have to attempt cultures in order to be included in this trial. So there may have been a bias toward the more severe of the non-severe kids, so to speak, having cultures done as opposed to the other kids.
Yeah, that was one of my, I would have loved to have seen that as well. And also, you could have you couldn't have a smear positive, but you could have an expert positive. And again, like you said, what does the chest X-ray look like with those? And I had one kid that had a completely normal chest X-ray. I always bring this little guy up because he came in and he had this little bark, and everybody had allergies, so everybody was on Claritin. But he barked like one time too many, and the nurse collected a sputum, and sure enough, it came back culture positive. I interrogated that chest X-ray because I didn't see anything. And so after he threw out the bug, I interrogated that chest X-ray a second time. Still didn't see anything. So so with that guy, like Jeff said, if he doesn't qualify at the beginning because he's culture positive, but his chest X-ray is stone cold normal, he never had a symptom, would I have used it for that? So there's a lot to it. Second question I thought was interesting from the same individual is, thank you, anonymous user. But again, good question. So it says some U.S. programs giving 6-month regimens by cell phone, video, DOT omit Saturdays and Sunday dosing and don't make up the 52 days at the end of the 6 months. So for children receiving 4-month regimens, would you suggest not omitting Saturday and Sunday? I think, we always count, like the way we do in our clinic is we get 5 days in, we count that week, so we're counting, how many weeks for treatment. But I personally think if I have a kid that's being on the 4-month regimen, I would leave packets for the parents to give on the weekends and be having that conversation the whole time. I would be trying to get those weekend doses in. And that's just kind of how we run it in our clinic. We set the parents up in the beginning. We let them know we'll be providing the meds. If they're crushed, we provide the powder and they sprinkle it in something yummy and give it to the patient. We give it to them in an opaque bag so that it doesn't, have exposure to light, but I'm not sure that everybody else does that. So now I wanted to hear what I know, Abby's over at UT and Jeff and Andrea are over at Texas Children and at Baylor. So I wondered, in your clinics, do y'all do something similar to that, or how do y'all manage the weekends?
Abby, you're muted, so.
Okay, can y'all hear me now?
Yes.
Okay. So I guess for infection, I'm used to us counting the doses pretty close, and then and I guess we don't worry so much about the weekends when we're dealing with infection. So I'm used to writing on the DOT orders Monday through Friday, like if we're doing daily rifampin.
Mm-hmm.
For disease, we've just always written Monday through Sunday. I've never looked at it that closely. I saw that question from the anonymous user and was interested to hear what consensus everybody might have. I guess my personal feeling would be if I was going with the 4-month regimen, I would want to actually be counting the doses to try to match the trial as close as possible. So that's something we all have to actually look at in the clinic, is specifying how attentive the health department needs to be to actually making sure those doses are counted individually to make sure we meet that actual number.
Yeah, for what it's, Andrea, go ahead.
Oh, no, Jeff, please.
I was just gonna say, for what it's worth, I know of no data whatsoever that supports the concept of not treating on Saturday and Sunday. So that's something programs are deciding to do, but it's not a data-driven approach. Now, we have done intermittent therapy before, but that's a whole nother kettle of fish, and it uses different doses of medication and so forth. So anyway, there's no data that supports that practice. Andrea.
And if they're on VDOT, I actually think it might be less confusing to parents to just do VDOT 7 days out of the week, right, as opposed to expecting them to do one thing during the school week and a different thing on the weekends. And so aside from, having to have somebody go in and view those videos to make sure it's an adequate video that was uploaded, it doesn't seem like there would be additional costs to the system to doing it 7 days per week.
Right. So I think, just for we usually, most of our children are either medicated by DOT, by our folks in our health department, or we're recruiting the school nurses and training them to do the toxicity screen. So we have them Monday through Friday, I'm absolutely certain, but we do provide the medications to the parents and have ongoing education about making sure that the child gets those doses on the weekend. But that is a really good question, because now you're going from 6 months where you might miss one here or there to where every dose is really important. Interestingly, the 4-month treatment shortening with the rifapentine and moxie also made specific to say that that was a 7-day-a-week dosing as well. So it gets shorter, but it gets more important. So
yeah, it's also
and,
it's also a message too, that this is so important. We want you to do it every day. We wonder why patients don't take medications. Well, they take some of their cues from us. So I think it as Andrea said, just makes sense to just say this needs to be a habit, and it needs to be a habit for the next 4 months or the next 6 months, and less confusing.
So let me see. I had another question. For small counties, what are you using to be able to provide IGRAs to your patients and be cost effective? Honestly, I mean, if the child is U.S. born, I'm fine with a TST. And if it becomes something that's that cost is an issue, I would say if you save those for the children who are BCG vaccinated, born outside of the U.S., that would be a save. But I would just say I'm personally really comfortable with a TST and a U.S. born child. And I want to throw in that Jeff is, kind of leaning toward, we're getting to the point where we're getting more toward the IGRAs, and I wanted to open up, to the other speakers as well.
So my mentor, Catherine Hsu, showed years ago when we had skin test antigens for non-tuberculous mycobacteria that at any given time in Houston, Texas, 25% of children will have some reaction to a standard tuberculin skin test. And she showed that it was mostly on the basis of exposure to non-tuberculous mycobacteria and cross-reaction. This is where I remind people, the skin test has hundreds of different antigens and proteins. The IGRAs only have two or three, and they're much more TB specific. The other thing about cost effectiveness is always interesting to me, because it's like cost effective for who? Because, if you do a skin test, well, it has to be red, which means either the patient has to come to you or you have to go to the patient or something. That's a cost too, and certainly inconvenient for the family. So there's a lot of different ways you can think about cost and convenience. Andrea, I think I cut you off. Sorry.
Yeah, it's okay. I think of all the downstream ramifications that happen when you have a positive skin test, right? And sometimes we think about the direct cost of the test and not those downstream things, right? And I think of my adolescent females who, they have a positive skin test, and all of a sudden they need a chest x-ray, and depending on where they go, they need to get a pregnancy test beforehand. And if they have a negative x-ray, then some places are going to make them get LFTs, although we don't, before they get them started on TB infection treatment. And there's a cost to that as well, in addition to, for some of the families, the cost of actually going to a clinic visit. And I think that's one of the reasons that, for some employee health programs, they made the decision that it was actually, in this is not taking into account sort of low-level positive QFTs. But they, many places have found it's actually more cost-effective for employees to get an IGRA done as opposed to pulling a healthcare worker out of the, their job, not once but twice, and sort of all these downstream ramifications. The other thing that I think doing a TST is predicated on people knowing how to accurately place and read TSTs. And I think that the group that is on this call is not representative of the general population of people who are placing and reading skin tests. And when I look at a skin test that was read the previous day as the ubiquitous 10 millimeter skin test, and I'm looking the following day within the 72-hour window at the child's arm, and I'm trying to determine, were they measuring a freckle? Like, I can't figure out what's being measured on the arm. That does not give me great faith in people's ability to accurately interpret a TB skin test. So that'd be the other argument.
I mean, if anybody thinks that there's a difference between a 9 millimeter and 11 millimeter reaction, I mean, it's interesting to me. In 2021, we quote unquote celebrated the 100th anniversary of the tuberculin skin test, and it's nothing to celebrate. I mean, I know no other area of medicine where a better test comes along and they don't retire the previous test. It's amazing to me. And the sort of hesitancy to, in essence, get rid of the TB skin test. It's a freaking bump on the arm. and it has so many problems. IGRAs aren't perfect either, but they certainly eliminate many of the problems that we have with the tuberculin skin test.
Still not a perfect test though either. That's the
Nope.
problem. We need a better test. And I feel like so many things downstream of what we do is based on that test, and we can't even get a test that tells us, anything beyond a response to something. So, and I should have mentioned that my comfort with the test only goes as far as who's placing it and reading it. If it's outside of my own clinic and I'm hearing it, like I smile real nice, but I'm like, no, yeah, and no. So.
Well,
But
so
I
I'm
mean,
gonna,
just for all of the mentioned, for all the reasons mentioned, yes. I mean, the IGRAs they show some superiority in actually getting past the reading and the placement in the reading is not trivial. I'm sorry, Jeff, were you going to say something?
I was going to tell a story, but I won't bore Andrea.
Hold on to that story. If we have time, we probably want to hear it. So here's a question, Jeff. What's the reliability of the QFT in infants younger than 6 months of age?
Well, reliability can mean negative when it's supposed to be negative and positive when it's supposed to be positive. I'm not gonna lie to you. It's not like there's huge amounts of data with this. And I would always also come back with what's the reliability of the TB skin test. Like the MDR kid I told you about, the skin test was negative, but the quantiferon was positive. So, that goes both ways. When I presented this data to the American Academy of Red Book Committee, I presented the data about skin testing and about IGRAs. I said, okay, close your eyes. I said, pretend that the IGRAs actually came first. And we were now deciding whether or not to endorse the tuberculin skin test. And after they stopped laughing, they said, well, no, of course not. So it seems to be good in the data that we have. Now, I can tell you that I have not heard of a single case. I hear about tons of things. I haven't heard of a single case of a child who was skin test positive, IGRA negative, and didn't get treated and then went on to develop tuberculosis disease that was not a direct contact of a case. If there's an Uncle Eddie and the kid's a direct contact, we're always going to treat, of course, if any test is positive. But for the kids who come over, like, immigration and so forth, nobody I know has heard of a single case. Now, it's going to happen, of course, but it's really rare. So I think it's pretty reliable.
One thing that is important is that we do need to have harmonization of guidelines between the pediatric community and what is done for refugee programs. Because as it currently stands, we have a very difficult time getting IGRAs done by our colleagues in the refugee program. And it's not by anything other than the fact that they are sort of beholden to guidelines from CDC, which have not yet changed to talk about IGRA use in the youngest children. And sort of given the data that Jeff presented, the continual insistence upon using TSTs in these patients doesn't make much sense. And what we end up doing is, we see them in clinic, and by that point, the family gets a cost of a clinic visit and a chest X-ray, and then we do our IGRA of choice in those patients. And I would say probably over 80% of the time, Jeff, those are negative in a child or even higher if the kid has no known contacts.
Yeah, probably even higher. And we personally haven't had any, and I've been doing this for 40 years, and we haven't had a single case where a kid like that we didn't treat went on to develop disease. And remember, the younger kids are at much higher risk of developing disease. So you would see it if it really were an issue. And we're just not seeing it.
Okay.
And I do realize one thing, that especially in smaller health departments and maybe with less pediatric experience, drawing blood on really young kids, infants, clearly that can be an issue. And I understand that can be a technical barrier that makes doing IGRAs more difficult.
And so the next question, I'll just answer quickly, was drug susceptibility testing done on the kids who were culture positive in the SHINE trial? Yes, they did do that.
They did.
And then the next question, as a clinician, would you favor treating plural culture positive asymptomatic children with 4 months or extend to 6 months if they have no other involvement on the chest X-ray?
Well, the criteria was uncomplicated pleural effusion. They didn't really that well define define what they meant by complicated.
Right.
So I think what they're trying to do is say if it's a localized pleural effusion or pleural reaction, you're fine. But if somebody has a pleural effusion up to the apex or an extensive one, but they never define what that means, which is really what the question asker wants. I personally, if it was significant pleural effusion, would still treat for 6 months. And that's based on clinical experience. And we've seen so many of these kids that have developed other complications and so forth. So I would be in the 6-month category. Andrea, Abby, you guys agree?
Yeah, I can't remember the last time I had an asymptomatic kid with a pleural effusion that was big enough to tap.
Andrea, your dogs agree.
For once, my dogs agree with me. Apologies. Moose, Bella, and Nacho really wanted to meet all 355 of you guys.
Okay. And so if someone under 6 months was high risk, would you do an IGRA and a TST and treat on the basis of either one being positive?
I'll take that.
I don't know the answer to that one. Yeah, but yeah, go ahead, John.
And here's what the AAP said. If you want to maximize specificity, you do an IGRA. If you want to maximize sensitivity, you do both a skin test and an IGRA. And in that case, it's kind of like lowering the skin test to 5 millimeters to consider it positive. You're giving up some specificity, but you're increasing sensitivity because they're vulnerable populations with a higher risk. So, and for instance, if we have a young kid that we're worried about TB disease, we sometimes do all three. We do the skin test and both IGRAs. And if anything is positive, we think that's pretty important evidence that TB may be the cause of the illness. So yeah, I think I will say this, that in theory, at least, doing both tests would increase the sensitivity, but at an expense of specificity.
Yeah. And I don't think, for me, if I'm highly suspecting that the child has TB, I treat. I mean, I can sort things out later, but I don't want to get behind that disease. If the child is in the house with a person who has active disease and the child is not clinically well and there's not been any other, they've been tested for COVID and flu and every respiratory panel that is available and nothing is coming up positive, I'm treating, I treat for active disease, and I can always kind of sort things out later. But that I would do both tests. I agree, and to try to increase sensitivity, but I think I would still treat.
So if you don't mind, Andrea, you and I have been doing this a long time. We have a very, very busy clinic. Can you even remember the last time we did a tuberculin skin test? Because I can't.
That we placed it? Oh God,
yeah.
No.
Yeah.
I think it was probably sometime after we recommended that a child get a BCG vaccine, then had to drive down to Matamoros to get it done.
Yeah, I mean, I'm just telling everybody, we practice what we preach. We just don't do TB skin tests.
I will say for those, the one problem that we have is we'll try a draw on a kid, and if we can't get either the blood ourselves or get them to the place where their pediatrician draws blood, then we'll place a skin test, but it's very rare.
Yeah, I think somebody asked a question, I saw it flash up there, about indeterminate for quantiferon or invalid test results for the T-spot. And yeah, they are a little bit more common in the younger kids, just as they're more common in the immunocompromised kids. And of course, if you get those results, it's as if the test was never done. And so you sort of start over again. And, remember, all these tests are based on lymphocytes. So if I get an indeterminate test because the positive control isn't working, and then I do a skin test and it's 0 millimeters, I don't necessarily have any confidence that that's an accurate result, because there's no positive and negative controls done with a TB skin test. So I'm not sure how much it really adds. We would just repeat the IGRA or do the other IGRA in a situation like that.
And one thing to just throw out there, just because I've seen it happen now a number of times, is that when the information that is conveyed by the panel physicians who do the screening before refugees and immigrants arrive in the U.S., sometimes it is worthwhile to look at the numeric value of the quantiferon. and to look at how it's reported. Because at many commercial labs, it's reported as TB1 minus antigen, TB2 minus antigen. And then for others, it's TB1 and TB2, and then you have to subtract out the negative control. And this is really important, especially for kids who have, relatively, like under 1 numbers on their quantiferons, where sometimes if you do the math, what has been read as a positive because they're just looking at the TB1 value can in fact be a negative test. And also, oftentimes our decision about what we do with these children, if in the absence of known exposures, will sometimes hinge upon the numeric value of the test, right? And I am more apt, for example, to do a T-spot in a kid who's got a quantiferon, TB1 minus nil of 0.36. And, but if they have, a TB1 minus nil that's 4, I'm just going to go ahead and offer, treatment for TB infection, assuming they have a normal exam and negative, symptom screen and a normal chest X-ray.
I think one question, Jeff, follow up to your answer. What if the repeat is also indeterminate?
Well, one thing I try to, first of all, I would want to know, is it indeterminate because of the negative control or the positive control? First thing I'd want to know is, does this kid have an adequate number of lymphocytes? Seriously, and I'd be a little bit concerned about this kid's ability to, is there some reason why this kid isn't responding appropriately? It's just like in the old days for the older physicians when we used to put on a control skin test that was something like Candida or SKSD or something that the child was supposed to react to. And if the TB skin test was negative, but the control was also negative, and then we used to say, okay, we need to do an immune workup now and figure out whether this kid has the ability to react for some reason. That's another nice thing, frankly, about the IGRAs is they have built-in controls. And so you get a little window into their immune system and how well it's functioning.
Okay, here's a question. Do you have a preference of T-spot or QFT plus?
Abby, you want to take that one?
For the most part, we don't have a preference. We actually have 2 different lab facilities depending on which hospital we're seeing our kids at, and one runs quantiferons and the other runs T-spot. So we've tended to see pretty much as far as like turnaround time, actually getting the results back without indeterminates, because there are some differences in techniques. So for the most part, we don't really distinguish. We've had few kids that have been immunocompromised, or for instance, be on like TNF alpha blockers, that we've preferred the T-spot, just because we would actually not get indeterminate results. So that's the only caveat that I would say kind of has had us be specific. And then we've sometimes seen with those indeterminate results, if one test is doing that or seeming to fail, going to the other test may actually give us a tangible result.
Yeah, agree. We've had kids with TB disease that we've done all 3 tests on, and we've gotten every possible combination of positive, negative, indeterminate you can imagine in different patients. And so I guess you could say that's a good thing that we have the different choices, because it helps sometimes to clarify. But I totally agree with Abby. I think the indeterminate results are much higher. I shouldn't say much higher. They're higher with quantiferon than they are with T-spot. Some of that is technical because of the shaking of the tubes and all that. But I think it's a little bit more than technical also. So, but QFT is a little bit more convenient. And for instance, our hospital brought QFT in-house, so we can now get them back pretty much within 24 hours, whereas T-spots more often take days before we can get the results back.
Right. Yeah, and that's same with us. We get a T-spot because our lab's in walking distance, and they're right in the next building, so our T-spots tend to come back quicker. But I think I've had a couple of kids that get sent to us. We get a report of a positive quantiferon, and we get some sheet that says positive, abnormal chest X-ray or normal chest X-ray. And instead, we can't get I like the actual numbers. So just like Andrea said, sometimes if they don't make the subtractions, the actual result is negative and they don't pick that up. So it'll say on the right that positive is that the abnormal would be positive, and they see positive and negative, and they see the word positive and they just run with that. So we like to see the numbers for ourselves, but sometimes if it takes a while to wait, we'll just order a T-spot. And I don't think I've gotten too many discordant things. I'm kind of like Jeff. I've seen discordance when we've ordered more than one test. I've seen, that kind of borderline. I've seen some of everything, but I don't think I used to kind of subscribe to the T-spot early on, more so just because you had a spin and count. And like Abby said, you would have a less chance that you got an indeterminate. But I really haven't seen personally any difference. I would be comfortable, equally uncomfortable with either test. So here's a question. If you rule out active TB in a child that you had decided, so after 2 months of treatment, you decide that the child actually had TB infection and you've treated for 2 months, would you stop and consider them treated for TB infection?
Well, I mean, that was the adult study that looked at that specific question, right? As they started people on RIPE, and then 2 months in, they realized that, they had more data at their disposal, and they decided they did not have disease, and they stopped, and those patients did fine. I think the rate limiting step with use of RIPE regimen for 2 months for infection was that the rate of hepatotoxicity in adults was unacceptably high. But I mean, I think Jeff and I have certainly had that situation arise where, out of an abundance of caution, we start a kid on treatment. And then we get more information and we decide, hey, you know what, that's, we have enough information to make a more nuanced decision about their diagnosis. And I mean, we've generally called it a day if they've gotten 2 months in.
Right. I agree. No, I've done same. And that was, I didn't, the study is originally where it was PCA and rifampin for treatment of TB infection. And one thing I've never gone back and seen how many children they had in that, or if they had any children in that. But again, with paucibacillary disease and knowing that I'm dosing children according to their weight, I tend to feel a little less uncomfortable. Okay. In the case of potential congenital TB, mom with active TB, would you do a TST or IGRA on the newborn? Oh, they're coming for you, Jeff.
That's a situation where I do all three.
Everything.
But it doesn't matter because I'm going to put the kid on some kind of medicine anyway. So, yeah.
So how soon will the 2024 AAP IGRA age restrictions be lift? I love that, lift on age restrictions. When will that be coming out?
Well, May of 24 is when the book is released. I think, however, they're going to add it to the so-called Red Book Online sooner. For instance, the two regimens, the SHINE regimen and the other 4-month regimen, already are on the Red Book Online, which constitutes AAP endorsement. So interestingly, this is weird. The CDC has not yet endorsed the SHINE trial. And the reason is there is currently a group that's answering 4 PICO questions, the SHINE trial, the other 4-month, and then some multi-drug resistant stuff. And the CDC is just waiting for that group to come out with its guidelines. I happen to be a member of that group, and I know for a fact that they are in fact going to endorse the SHINE and in fact going to endorse the 4-month regimens. So, it in essence, I think has approval of all those organizations. Last time I looked, the IGRA thing was not yet on the Red Book Online, but we've had discussions since then. So I need to look and see whether or not they've posted that or not.
Okay, and someone says that they're affiliated with a busy county TB clinic, and I don't think our nurses do enough TSTs to maintain their proficiency. If you get past Jeff and his venom for the IGRAs, if you have to use them, actually, Heartland does have a TST training. So if you email Delphina, who is the lead trainer for this particular training, she can let you know about any of those that are available. And I will say, I'm not sure, I'd be interested in others, whether they're looking at using the SHINE, evoking the SHINE trial and doing the shorter 4-month regimen in the different states, since we have different individuals that are that are represented here on the call. We in the state of Texas are working on guidance, but probably in the beginning will be more running through the expert, the TB experts that we have, reviewing some of them with the health departments before we actually roll it out to just being able to use without some kind of guidance. And interestingly, you know, when we're doing all of the chest x-rays, there's a lot of difference of opinion. So I wondered if any of the individuals on the call, if we change their comfort level with it, or if they feel the same, or, you know, I'd be very interested in the participants, because that's about the end. We had one last question. What about a positive TST and negative QFT? While, you know, folks might, if they want to add something to the chat, I think I'll kind of hand that off to Jeff. I know you need a little bit more information. If I gave you a child with a positive TST and a negative quantiferon, what your thoughts would be on that.
It depends on why the kid was tested. If there's TB exposure to a specific person, that's positive. The child gets treated as TB infection, appropriately evaluated and treated, if any of the tests are positive. But usually in that situation, the only thing is sort of immigration, foreign birth. And of course, many of those kids have had BCG vaccine, and that's the reason why they have the falsely positive tuberculin skin test. But those are the kids, if they have no specific risk factor and it's mostly related to just immigration from a high burden country, we do not treat them. And I'm going to say it again, I don't know how many hundreds of kids like that we've seen, Andrea. We have not had a single one that we're aware of come back with tuberculosis disease.
Yeah, and I would also say that as a general rule, I completely disregard skin tests that are divisible by 5, because it makes me think that people did not actually measure the skin test size.
Oh, I sat on we were doing the panel physician updates, and I told them everybody that comes to my clinic has a TST reading of 10 millimeters, every single one of them. Like that's it. There's no, you know, 7, 8, 9, 10, 11, nothing. Every single one of them has a 10.
Okay, so I'm gonna tell my story now.
Tell your story, Jeff.
We had a girl with Crohn's disease who needed to get TNF alpha inhibitors. And she was from Mexico. They did a TB skin test on her. It was 0 millimeters. They went ahead and treated her. She did fine, except that she left. She went back to Mexico. She reappeared about 18 months later with worse Crohn's disease. So they wanted to put her back on the TNF alpha inhibitor. So they did a TB skin test. And there's 3 different notes in the chart. The first nurse goes negative. The second nurse says there's induration, likely positive, we'll discuss on rounds. And the third one is from a pediatric resident, and it said redness, no induration, negative test. So they started the kid on infliximab, and 8 weeks later, she came back with horrible cavitary tuberculosis. So I sat down and talked with the resident, and I said, Michael, have you ever seen a positive skin test before? And he said, no. And I said, well, you've seen one now. And he didn't know what he was seeing. He didn't know what he was feeling. He'd had no specific training in it. You know, if health department people who are trained are doing skin tests, that's fine. I got no problem with that. But the problem is now is a lot of them, even if they're placed in health departments, are being read by somebody else. And I have no confidence that they know what they're doing in the interpretation of the skin test.
All right, we've got 3 minutes. Anybody want to, like I said, have you changed your mind any about the treatment shortening? Have we muddied the waters? Is it clearer? Is it more confusing? There's over 300 of y'all on there. All you need is one of y'all to get started. All right, we got a clear and thank you. I guess the question is, my clear and thank you. Are you ready? Like, do you feel like you can do it? All right, less muddy.
The one thing I'm going to say is Lisa said it in a very nice way, but we're not using the SHINE regimen now because the state hasn't officially approved it, which means they're not allowing local health departments to do it. Even though we've pointed out to them, it's going to save them a bunch of money because it chops 33% off therapy, not only of the drugs, but also of the DOT. So I don't know if other states are having a similar issue with, you know, making it sort of formal and approved so that the state will provide the medications for that regimen. So that's just a funny quirk that we have going on right now.
Yeah, we got a twofer in Texas. We've got an INH shortage right now, but we're allowed to use that in kids, but we're still, like I said, our state's going to rule it out with some restrictions. They'll be talking to one of the 4 people you see on the call about it before they'll roll it out for just kind of general consumption.
And realize that just because it's not rolled out now, if we start a kid on RIPE, we always have the potential of, when they get to 4 months, if the regimen is approved, truncating at 4 months of treatment time, right? Because rarely do we have a family that gripes at us when
Right.
their child's therapy doesn't go as long as they think it's going to go, right? It's the
Sure.
families, you tell them 6 months and they're like, dang, they need 9 months. Those are the families that give me the evil eye for the next quarter year.
Yeah. All right. Well, I think we're right about at the hour, so I want to hand it back over to Delphina. Just want to say thank you on behalf of Heartland to our extended family down in Houston with Jeff and Andrea and Abby, always stepping in and willing to share their knowledge with us. We appreciate you three more than you know. We're missing in absentia Kim Smith's our honorary other family member down there. So we'll just hand it over to Delphina for any parting thoughts.
Yeah, so thank you so much to all of our speakers. Let's give them a virtual round of applause. Okay, thank you. So just if you could please just stay online, I'm going to share the QR code to complete the evaluation. So just a reminder, for those of you who are viewing in a group, please be sure that you complete the sign-in sheet for everybody in your group. And then also all those people, the group viewers must also complete an evaluation. The deadline to complete this evaluation is tomorrow. So please be sure and complete that evaluation. I'll match the evaluation with the attendance list, and then I will send everybody their certificate for your continuing education. Bear with me a second. I'm going to share the slide with the QR code. So you want to take a picture of this slide, and then you can scan the QR code. But just please, please, please complete this evaluation by tomorrow. I will close the poll, close the business tomorrow, which is 5:30 p.m. So Central Time, 5:30 p.m. Central Time. I will close the evaluation link. So please be sure you complete this evaluation by that time. Again, I'm going to match the webcast attendance list with the evaluation completion list, and those are the people that will receive their certificate for CEs. If you have any questions, please feel free to email me. I'll put my email in the chat box for you. I want to thank everybody for your patience with some of the issues that we had. It's been great having such a large number of people on our webcasts. And I want to thank everybody. Once again, I'm going to leave this slide up for a little while. You can take a picture of it. But I will pull this slide down in about maybe the next 5 minutes or so. Thanks, everybody.